يس اوكي كل شيء تمام.
اوكي كل شيء تمام، يعطيك العافيه.
الله يعطيك العافيه. شكرا بتول. Good afternoon everyone. It's a great pleasure to be with you today and to moderate this session. Primarily I will talk about bilateral breast cancer. I will show a case report from our practice. So the objectives of my talk, I will talk briefly about the epidemiology of breast cancer, and also I would present 2 slides about the risk factor, and after that I will talk briefly about bilateral breast cancer, and I will present a case, interesting case actually from our practice. So the epidemiology of breast cancer, unfortunately, breast cancer is very common worldwide and in our country as well. It's the most common cancer among women with life risk about 13.4%. That's mean in each 8 women, there is 1 woman will mostly develop breast cancer. The estimated number of cases in 2020, according to the American Cancer Society, it's estimated to be more than 279,000 of cases will be diagnosed in 2020 for this year in the United States, with estimated number of deaths more than 42,000 of deaths for this year in the United States only. Breast cancer have a variable geographical distribution. The incidence is higher in Northern Europe and North America, with lowest incidence in Africa and Asia. This slide shows the incidence of breast cancer and the percent of death or mortality rate of the breast cancer over the last few decades. If we follow this line, the first line, which is representing the incidence of breast cancer, we note that after the age of or the early of the 1980s, there is an increased number of breast cancer, increased number of the female who diagnosed with breast cancer. Actually, this is increase in the incidence. It's related to the use of screening mammogram and improvement in the diagnostic modalities and the diagnostic modalities of a breast cancer. If we follow this line here, which is representing the death of a breast cancer, we note that there is a steady decline in the mortality rate for breast cancer over the few decades. Actually, this decrease in the mortality rate or decrease in number of deaths for breast cancer, it's related because of 2 things or 2 factors. The first one is the using of screening mammogram. This is led to diagnosis of breast cancer in earlier stage, and we know that breast cancer, when diagnosed in early stage, it's a potentially curable disease. And the other cause for decreasing in the incidence of death or dropping in the mortality rate of the death decrease in the mortality rate over years. This is the second cause because the development of newer medications and more effective medication, and also improvement in the management of the patient with breast cancer, and this has led to decrease the death or number of deaths for those patients. The risk factor of breast cancer, I can divide it for modifiable risk factor and non-modifiable risk factors. The modifiable risk factors, the first one is the race. There is a variability according to the race of the incidence of breast cancer. Actually, before the race, the gender as being a female, this is a strong risk or it's strong enough to have a breast cancer or to develop breast cancer. As we said, the race is very important, and there is variability of the incidence of breast cancer according to the race. Also, family history and personal history. Any family history, if there is one member of the family having breast cancer, this will increase the risk of breast cancer to the other member of the family. Also, any woman who diagnosed with the breast cancer, later on she had a higher risk, about 8-fold higher, to develop another breast cancer in her life. Reproductive history is very important. All the studies showed that the breast cancer is higher on those who are nellipara, and also radiation exposure for the patient who diagnosed with Hodgkin lymphoma, for example, in early adolescent, and they're receiving radiotherapy to the chest wall or to mantle field radiotherapy. This is put those patients under the risk of developing breast cancer later on in their life. Genetics factor, we have many genetics actually, which is linked to the development of breast cancer. For example, we have BRCA1, BRCA2, which is the most popular genetics known for to be linked with breast cancer. And also we have another genetics factors like ATM, like PALB2, and many genetics alterations that links or increase the risk of development of breast cancer. Menstrual history is very important because the breast cancer is higher in those who are having early menarche and late menopause, and the age also is very important risk factor, and it's one of the most important risk factor because the risk of a breast factor is increased with age. The modifiable risk factor, obesity, increasing the body mass index, it's linked to increase the risk of breast cancer. Nulliparity also is a risk. Breastfeeding is considered as protective against breastfeeding is a protective factor for the breast cancer. Hormonal replacement therapy, it's reported that the hormonal replacement therapy is increasing the risk of breast cancer. Also, it's linked to alcohol consumption or heavy alcohol consumption, mainly not moderate or not mild alcohol consumption. Also, exercise is considered as another protective factor. If we have a patient with bilateral breast cancer, the breast cancer and the contralateral breast, it's either synchronous or asynchronous, which is also known as metachronous, and also could be or either metastatic disease from the primary breast. Synchronous breast cancer, that's mean when the cancer in the both breast develop at the same time. You receive a patient with bilateral breast cancer, this is synchronous breast cancer. The metachronous, when the cancer of breast cancer or in the both breast develop, but in different time. For example, you receive a patient with breast cancer, and after a few years later, she developed another cancer in the other breast. So this is a metachronous breast cancer. It's not synchronous breast cancer. And also, in rare cases, sometimes the breast cancer in the other breast could be metastasis from the primary breast cancer. So bilateral breast cancer, the synchronous bilateral breast cancer is a rare event. It's reported the incidence is about 0.3% for synchronous breast cancer and about 12% for metachronous breast cancer. So the synchronous breast cancer is it is uncommon event to be seen in practice. The prognosis of bilateral breast cancer is thought to be poor. In spite, there is some data suggested that similar survival for bilateral breast cancer as comparing to the unilateral breast cancer, but actually the prognosis of bilateral breast cancer is poor compared to the unilateral breast cancer. When the patient diagnosed with synchronous bilateral breast cancer, the tumor, which is diagnosed first, is usually having the larger size, of course, when comparing to the contralateral tumor. And the stage of the patient, the stage of the disease of the breast cancer will be the stage of the higher stage tumor. And the most common histology for the patient who develop bilateral breast cancer, usually we see this in lobular carcinoma. So the lobular carcinoma or invasive lobular carcinoma, it's well known that it's tend to cause bilateral breast cancer. But today, actually, I will present a case, a rare case from our practice, who having developing bilateral or presented with synchronous bilateral invasive ductal carcinoma. I present my patient is a 36-year-old female. She is lactating. She is delivered 4 months ago before 4 months ago before presentation to the clinic. She presented with bilateral breast masses for 2 months duration. We did mammogram for this lady. Actually, the mammogram showed that the right breast showed at least 2 lesions with axillary lymph node enlargement, and the left breast shows multi-ill-defined densities. After that, we took biopsy from both breasts, and the biopsy, as showed here, the right breast, the biopsy is consistent with invasive ductal carcinoma, grade 3, hormone receptor negative and HER2 negative. So it was consistent with the triple negative invasive ductal carcinoma grade 3. And the left breast biopsy also it shows that invasive ductal carcinoma grade 2, hormone receptor, estrogen receptor positive in 30%, progesterone receptor negative and HER2 positive. So she has different tumors in both breasts. There was no distant metastasis by staging. Her CT scan was free, and the bone isotope scan it was free also. There was no distant metastasis. This lady started on a neoadjuvant chemotherapy. Neoadjuvant chemotherapy. When I said the neoadjuvant, it's mean the chemotherapy which is given before the surgery. So it's called the neoadjuvant chemotherapy. So we gave this lady neoadjuvant chemotherapy, which is consistent with AC protocol, adriamycin with cytoxan, followed by taxotere and Herceptin. Herceptin, it's the trastuzumab, which is the anti-HER2. targeting the anti-HER2. This protocol started in 2017. I saw those lady for about 3 years ago at the first time, of course. After she completed the chemotherapy, the neoadjuvant chemotherapy, she underwent surgery. And we did bilateral MRM, modified radical mastectomy. After modified radical mastectomy, the histopathology report, it was shown that the right breast, there was 2 foci of residual invasive ductal carcinoma, which is the largest was 10 millimeter in dimension, which is staged as T1N0 pathological stage. And the left breast, there was complete response to the chemotherapy. There was no residual tumor, with no residual tumor at the left breast after the neoadjuvant chemotherapy. After that, the patient is received adjuvant radiotherapy to the chest wall, and she planned to continue on Herceptin, trastuzumab for 1 year, and she started hormonal therapy, tamoxifen plus Zolotix. On October 2018, the patient developed left ventricular impairment. She developed heart failure by 2D echo, which is a side effect of the Herceptin. It's about 4% of the patient, around 4% of the patient who are receiving Herceptin, they may develop this side effect, which is heart failure or LV impairment. So unfortunately, our patient is developing LV impairment on October 2018. And after that, we stopped or hold the Herceptin, and we continue here on hormonal therapy, Zolotix and tamoxifen. Unfortunately, a few weeks later, she presented to the clinic complaining of dizziness and blurred vision. And we did for her brain MRI. And this is her brain MRI. Unfortunately, the brain MRI showed that there is an right occipital lesions surrounded by vasogenic edema, which is consistent with metastasis, with the brain metastasis, single brain metastasis. After that, we consult the neurosurgeon. After that, the neurosurgeon, he performed a metastectomy for this lady in December 2018, followed by brain radiotherapy. And in January 2019, her brain MRI showed there is no residual disease and only post-operative changes. She did well and not complain, and there was no complaint. Her lab data, it was okay, and kept for another hormonal therapy, which is Aramidix and Zolotix. Unfortunately, after about less than 1 year, she brain MRI, she presented to complain, or she presented again complaining of headache and blurred vision. And we did another MRI in November 2019, and there is a recurrent large metastatic deposit at the site of the surgery in the right occipital lobe. So she developed a relapse or local relapse of the brain metastasis. And another surgery is done, metastectomy, on the 27th of November 2019. And the pathology, it was consistent with also metastatic carcinoma, breast origin. It was triple negative breast cancer. It's consistent like what we see in her right breast. Okay. This is the histopathology of the brain lesion, or the brain lesion consistent with metastatic carcinoma of a breast origin. It was hormone receptor negative and HER2 negative as well. In April 2019, this is her brain MRI. There was, as you see here, it was a clear. There is no evidence of residual disease or metastasis by her brain MRI. But unfortunately, on February 2020, this patient started again to complaining of the deterioration of her general condition and also headache and also another complaints. And we do restaging for her, and unfortunately, she developed lung metastasis and brain relapse, as you see here. And there was no role for surgery at this time, and we kept her on palliative management, palliative chemotherapy. So conclusion from this case that synchronous breast cancer is a rare event and warranted physician awareness and screening for the contralateral breast. When you receive a patient with breast cancer, you have to screen for the other breast before starting the treatment plan. And the etiology of bilateral breast cancer is uncertain, and most of the contralateral breast cancer diagnosed by mammography and commonly having lower stage tumor, and the prognosis of bilateral breast cancer is usually carrying poor prognosis when compared to the unilateral breast cancer. And thank you very much. Any questions? I will be happy to receive questions. Any question? Do you hear me? سامعتني بتول? Do you hear me? بتول سامعتيني؟
سامعينك دكتور أيمن يعطيك العافية.
Yes, it seems there is no question. الله يرضى عليك. It seems there is no questions. So at this point we can move to our next speaker. Our next speaker is Dr. Tania Jilat. Dr. Tania, she is a hematology specialist from the Royal Medical Services. She's graduated from the University of Jordan, and she completed her hematology residency at the Royal Medical Services, and currently she works at the hematology. She works as hematology specialist at Prince Imam Center for Research and Laboratory Sciences in the Royal Medical Services. Dr. Tania today will talk about the prevalence of factor VIII inhibitors among children with hemophilia A. Please, Dr. Tania, the mic is yours.
شكرا دكتور أيمن يعطيك العافية أول شيء عن حضرتك. شكرا لك.
الله يعافيك.
شكرا على الانترودكشن. رح أعمل أنا كمان أجرب الشير سكرين هلا إذا شايفين خبروني. خلينا نشوف.
Yes, it's there, Dr. Tania. Yes.
Okay.
Yes, you can start.
تمام شكرا.
تمام.
Okay, today I will talk to you about the prevalence of factor VIII inhibitors among children who are diagnosed and treated at the Royal Medical Services diagnosed with hemophilia A. Let me just, okay. As we know, hemophilia A is a hemorrhagic diathesis that is ascribed to a specific either deficiency or dysfunction of a certain factor, which is factor VIII, an important coagulation factor in the intrinsic pathway of the coagulation cascade. Now, hemophilia A together with hemophilia B and Waldenström disease, they make up more than 95% of all hereditary coagulation factor deficiencies. It is inherited usually in an X-linked recessive manner, or it can occur due to de novo mutations in the factor VIII gene, which is located on the X chromosome in up to 1/3 of the cases, the most common of which is the inversion of intron 12. This is seen in about 40–45% of the severe cases of hemophilia A patients. It is seen in about 1 in 5,000 to 10,000 male patients, as is the case in many X-linked recessive disorders. It's usually seen in male patients rather than female patients. The presentation usually is in different patterns of bleeding, and the characteristic one of which is bleeding into joints, which we call hemarthrosis. The presenting symptoms usually depend on the severity of the disease, and the severity of this disease is usually classified according to the degree of the activity of factor VIII in the plasma. It is classified into severe, moderate, and mild disease. The severe disease usually they have a factor activity of less than 1%, and the moderate disease is a factor activity level of 1 to 5%, and if it's more than 5%, a patient will usually have the mild form of the disease. The mainstay usually of treating such patients is usually by giving them infusions of the deficient factor, which is the factor VIII, usually replaced by pathogen-free or either plasma-derived or recombinant concentrate. And the management is usually either prophylactic or on demand. In countries that have lack of resources, they can manage with cryoprecipitate or fresh frozen plasma, which are also rich in factor VIII. Now, the burden of this disease, it carries both health and financial burdens. Now, the financial burden is usually heavy because the prophylactic transfusions that enable hemophilia A children to lead normal lives in terms of either span or even quality of life, it will cost yearly up to $300,000 in the United States. This depends on the severity, the treatment options, and many factors. So you can see that is a heavy financial burden. Now, there is also a health burden on the patients themselves, and the most challenging complication in this type of treatment is the development of inhibitors against the infused factor, which is the subject of our talk today. So these inhibitors are polyclonal IgG alloantibodies. They are directed against the infused factor VIII protein, which is an exogenous material. So this will inhibit the function and the activity of this factor in controlling the hemorrhage in the human body. Such cases of patients who develop inhibitors, they exhibit resistance to treatment, and they will require higher doses of factor replacement, and they are more susceptible to arthropathy and bleeding episodes, and they will have a worse quality of life in general. This also as well poses an enormous economic burden, as it also increases treatment costs by 2 to 10 times. So the aim of our study was to determine the prevalence of these inhibitors among hemophilia A children in the Jordan Royal Medical Services. The study was conducted in a retrospective manner, and we collected data for 165 children who were treated on demand for hemophilia A. Their ages ranged between 6 months and 16 years, and the study period extended from 2003 to 2018. Now we collected samples from each patient, 4.5 ml venous blood collected into 3.2% trisodium citrate tubes and sent to the coagulation department, where it was centrifuged to obtain platelet-poor plasma. And we ran many tests on this platelet-poor plasma for the patients. The tests were the included tests were PT-PTT, the factor VIII level, and screening tests for factor VIII inhibitor on the STAG analyzer. And then we ran a screening test for the inhibitor, which involved mixing studies, where we use our magic in the lab and mix samples together. And for each patient, we will label more than one tube, 3 or 4 tubes for each patient. And depending on the partial thromboplastin time readings in the different tubes, we will infer whether the patient has an inhibitor or not. So if in case the screening test revealed a positive result for the inhibitor, we will do the next step, which is to confirm the result and to quantitate the inhibitor that is present using the Bethesda assay. The Bethesda assay involves incubating mixtures of patient plasma with normal pooled plasma, and the residual activity of factor VIII will be compared between the patient's mixture and the normal mixture, and then we will report these results in Bethesda units per ml. So the definition of a Bethesda unit, it is the amount of inhibitor that will neutralize 50% of 1 unit of factor activity after an incubation period of 2 hours at 37 degrees Celsius. And depending on the inhibitor level, we divided our patients who were positive for the inhibitor into high titers and low titers. Patients who had Bethesda units, more than 5 Bethesda units per ml, were labeled as high titers, and the patients who had titers below 5 were labeled as low titers, or also called as low responders. We analyzed the data using the program SPSS, and the p-value was considered significant when it is below 0.05. Now, inhibitor testing was performed only in 3 situations: when patients receive on-demand treatment, and in the assessment of treatment-resistant cases, and before surgeries. Now, of the total 165 male patients that were included in this study, we had the majority of them had severe hemophilia. Almost 2/3 of the patients had severe hemophilia with the factor level less than 1%. Almost 16% of them had moderate hemophilia, and 17% of them had only mild cases. 20 patients out of the 165 patients had factor 8 inhibitors, which amounts to 12%, which is not uncommon. This is a very high percentage, like 1 in 8 patients of hemophilia A will have factor 8 inhibitors. Now, in severe cases, the percentage was higher. It was almost 16%. The majority of patients with inhibitors, almost 90% of them were high responders, and only 10% were.
أنا مرة ألقيت مباشر.
بس زملائنا الأفاضل لو يتأكدوا إنه كل واحد عامل ميوت للميكروفون بليز.
اوكي شكرا دكتور أيمن. هلا عندنا المين inhibitor level among low responders was only 2.4, and the mean level in high responders or high titers was 116, and we found a significant association between the age at the onset of treatment and the inhibitor titer level. Now, this is the classification of the inhibitor titer levels. It ranged between 1.8, the lower titer that we found, and the higher titer in our group was 563 Bethesda units. As you can see, in low titers, the average was 2.4, and in high titers, our average was 116. This shows you the prevalence of the inhibitors in relation to the severity of the disease. So as you can see, the highest percentage of inhibitors was found in severe cases, up to 16% of these patients, and 7% were found in moderate cases. As you can note, mild cases, no patient had positive inhibitors in their plasma. So as you noticed, there was an association between the severity of the disease and the incidence of factor 8 inhibitors. Few studies have been published that studied the prevalence of inhibitors among Arabs with hemophilia A. For example, the range was between 5% to 30% in Arabic countries. 5% was the prevalence in Tunisia, and 30% was the prevalence in Saudi Arabia. These differences in prevalence rate was attributed mainly to treatment protocols, ethnicity, maybe the study design, and many different factors. The factors that influence the development of these inhibitors are usually divided into two groups. One group is patient-related and one group is treatment-related. The patient-related characteristics that influence the appearance of these inhibitors include genetic factors, immune response, and ethnic groups. Studies in the United States, for example, they noted higher rates in certain ethnic groups like Hispanics, Blacks, Asians, and Indian groups. Also, groups with positive family history and patients on prophylactic treatment showed lower rates of inhibitors. The factors, other factors that are treatment related include the duration of treatment, the intensity of it, the age at the first exposure, and the type of product. For example, the product type, usually the patients receive either plasma-derived factor or recombinant factors. So the risk was higher when patients used the recombinant factor 8. In our study subjects, only 20% of our subjects received the recombinant factor. The vast majority received plasma-derived factors, so we had lower rate of inhibitor compared to other countries. The treatment duration, the intensity of the treatment, and the younger age at the first exposure of factor 8 increased the risk of developing inhibitors. The age range of our 20 positive inhibitor hemophilia A patients was between 6 months to 15 years. Almost 2/3 of our patients were younger than 5 years old, which is related to their need for repeated exposures and them starting their treatment at an earlier age. Now, 18 out of 20 patients, which is almost 90%, had high inhibitor titers. Most of these patients, they have uncontrollable bleeding and they do not respond to replacement therapy, in contrast to patients with low titer group. This finding calls for further exploration for immune tolerance induction treatment, for example, to help them in their management. Now, to speak about the genetics, the genotype in factor VIII is important determinant of inhibitor development in patients with, especially with severe disease. It is well established that the nature of the mutation is a predisposing factor. Mainly, the most common one which we talked about is intron 22, which accounts for almost 50% of the mutations in severe cases. Notably, in our study, 6 out of the 20 patients who were positive, which is 30% of them, belong to 3 families where severe hemophilia A occurred in 2 siblings per family. There was an association between developing inhibitors and the family history of inhibitor formation among our patients, which was a significant positive correlation as well. In Jordan, for example, in our lab, it was difficult to determine the genotype for factor VIII mutation in our patients. However, there were other studies in Jordan that were related to this subject, like Awidi et al. They found that 13% of Jordanian hemophilia A cases who carry null mutations and 6% of those who with loss of function mutation, they developed inhibitors against factor VIII. A positive family history of inhibitor and incidence of the inhibitor formation has been established in other previous studies in Jordan, which is similar to our study. In conclusion, the inhibitor development, it poses a heavy economic and health burden. It is not uncommon in Jordanian hemophilia patients, particularly in patients with severe cases. So prospective studies using centralized inhibitor titer measurement as well as standardized and comprehensive data collection are needed to evaluate either modifiable and non-modifiable like genetic factors that contribute to the inhibitor development, and maybe new protocols and strategies to be implemented in order to reduce the risk and to identify positive cases. Maybe genetic counseling and national screening to also identify high-risk gene mutation may help for better management of our dear patients. Thank you for your listening.
يعطيك العافية دكتورة تانيا. Thank you very much for this fruitful presentation. Actually, يعني
الله يعافيك. شكرا.
I enjoyed it very much actually. شكرا كثير لك ستي.
يعطيك العافية. شكرا.
Yes, يعطيك ألف عافية. شكرا كثير. Now we move to our next speaker, Dr. Maher Khadr. Dr. Maher Khadr, he is a pediatric oncology and hematology consultant. He is the chief of pediatric hematology oncology division in the Queen Rania Hospital for Children. Dr. Maher today will talk about ITB and treatment or management guidelines, and he will present a case from his practice for a futuristic case about ITB. Dr. Maher, تفضل.
شكرا دكتور أيمن. I will try to share my slides. I don't know if you can see it, Ayman.
Yes, I can see it.
Okay. Okay.
بس لو تكبرهم على سلايد شير بالله دكتور ماهر بليز. يس فول سكرين يعني سلايد شير. مش يس فول سكرين اللي هي at the bottom of the screen.
هيك مش واضحين دكتور ايمن؟
واضحين بس لو تعملها فول سكرين يعني احسن. يس
فول سكرين.
كنترول ايه دكتور؟
كنترول ايه
هاي تحت السلايد.
ايوه اخر.
ايوه
هيك واضحه؟
Yes,
تمام.
it is. Yes, yes.
تفضل.
تفضل دكتور.
إن شاء الله. شكرا لكم جميعا. السلام عليكم ورحمة الله وبركاته. It's my pleasure to be with you today and to talk lightly about a relatively common hematologic subject in the pediatric age group, which is the immune thrombocytopenia. And in the coming, I guess, 20 minutes, I will talk about some cases to make things easier and simpler for the audience. And I will review if possible the terminology of the ITP. And then we will go for the management and the updated management. I guess there is much debate and there is confusion between several even pediatricians and hematologists regarding the management and where to go and what to give. I will start with the case, this female patient in Queen Rania Abdullah Hospital, whose age is 5 years, presented to us in November 2019 with easy dry bleed. When we say dry bleed, what we mean with it, dry bleed is skin type of bleeding. And we will talk about the skin type of bleeding. I guess we are talking about something mimicking platelet type of bleeding. This is how is the language between the pediatrician and the hematologist. And when you say platelet type bleeding, something superficial like the skin or mucous membrane. And when you talk about factor type of bleeding, you are talking about something more deeper, bleeding, more deep-seated bleeding, like something in the joint or something in the muscle. This type of bleeding, which is dry type of bleeding, it was something of somewhat like more than 2 weeks after some infection in the upper respiratory tract. And they were scattered in the upper and lower limbs. Digging in the history, there was no family history of similar condition, and there is no previous similar condition in the patient, and there is no drug history. Examination in this patient is very important. Once you say that this patient is playful, it means something good for you. Because if the patient is septic and presented with the same complaint, it is not accepted for any pediatrician to miss a case of septicemia or DIC. But when you see that this patient is playful, you are happy. If you are not diagnosing the patient, someone else will diagnose without hazard or risk on the patient's life. The patient vital signs also very important to be measured. And the patient's vital signs were stable. And again, if the patient has something like high temperature, we will consider something apart from the ITP, something like sepsis, something like DIC, which consumes the platelets. If the patient has hypertension, you are talking something apart from the ITP, simple ITP, something like systemic manifestations or systemic disorder that is causing thrombocytopenia. The absence of pallor is also important because if you are thinking in lines of involvement in this patient, and this patient most likely has a platelet line of involvement, once you say that he is not pale, you are talking something apart from more than one line of involvement. It is only monocytopenia. Phenotypically, he was normal, and this is also important. If the patient is phenotypically abnormal, is he failing to thrive? If the parameters of growth, they are delayed, you are talking or thinking something mimicking the Fanconi anemia, or if the patient has abnormal upper limb, flexion of the upper limb, you are thinking of TAR or radioulnar synostosis associated with thrombocytopenia. Examination ما بعرف أيمن سامعيني أيمن؟ لأن التكنولوجيا مش قوي. سامعيني هيك؟
دكتور سامعينك.
We heard you very well, Dr.
Okay.
Go ahead.
Okay.
Yes.
Okay. The examination also revealed dry, few scattered bleeding in the form of petechiae, bruises, and non-palpable ecchymosis. They are all important. Petechiae, bleeding less than 3 millimeters. Bruises something between 3 and 10 millimeters. Ecchymosis something above 10 millimeters. Non-palpable ecchymosis means a lot for us. We are talking about a platelet type of bleeding. But when we are examining a patient with palpable ecchymosis, you are thinking more of vasculitis rather than. So the examination is very important for you. Also, the patient was revealed to have a hemorrhagic type of bleeding in the wet type of bleeding in the form of hemorrhagic enanthem. The patient has some bleeding in the buccal area in the mouth. Absence of lymphadenopathy and hepatosplenomegaly mean both a lot for us, which means that there is no lymphatic infiltration regarding whatever the patient is having. Yes. And then we went in this patient for the lab. The patient was having isolated thrombocytopenia. What is meant by isolated? Only one line. The other lines, the RBCs line and the white blood cells line, they are both normal. Large-sized platelets, also macrothrombocyte. Macrothrombocyte is something different than the giant platelets. It is not accepted to go and say giant platelets and the patient is having large platelets. Large platelets means something above 4 micron. Giant platelets something above 7 micron. When are we talking about something above 7 micron or micrometer? We are talking about a platelet large enough to be even larger than the RBCs. And those giant thrombocytopenias, they have another differential diagnosis, like Bernal-Solier, which has some pathology regarding the glycoprotein 1B, which is important as a receptor for von Willebrand factor, like gray platelet syndrome, which has absence of alpha granules, like May-Hagelin and MIH9 mutation. This is something different. What are we talking about? We are talking only large platelets. The patient was only large or increased MPV. Scattered platelets also important to think of ITP. It is not abundant. If the field is full of large or giant platelets, you are talking about some other things other than the ITP. Absence of a blast, most likely, but not always, you are not talking about malignancy like leukemia. Absence of schistocytes is the fragmented RBCs. Absence of fragmented RBCs makes microangiopathic hemolytic anemia much less likely. In the film also, it is important, it helps a lot to say that it is not pseudothrombocytopenia. Kidney function was normal for the patient, and we decided that this patient, we don't need to go for a bone marrow examination, and we established the diagnosis of immune thrombocytopenia. And this is the pseudothrombocytopenia. Pseudothrombocytopenia, blood film is very helpful. There are clumps of platelets. Why there is clumps in edited tube? Because the edited tube will make some conformational changes of the glycoprotein 2B3A, which is above the platelets, and which will make the epitope more prone for the autoantibody. And the clumps in this patient, you can see them, which are blue in color. What the patient received actually different modalities of treatment, including observation, corticosteroid, and immunoglobulin with no response. And then we decided to go for another new modality, second line treatment, which is the oral thrombopoietin receptor agonist. And we choose the L-Thrombobag because of the availability, and the patient responded well. This is regarding our patient. And back to the ITP, which is the most common cause of thrombocytopenia in children. The peak is between 2 and 5 years, usually preceded by viral infection, and occurs usually in late winter. And most our patients present with alarmingly low platelets, something below 20,000, and fortunately, the majority even spontaneously resolve in the pediatric age group. Immune thrombocytopenia, you talk, it is not idiopathic. It is not idiopathic thrombocytopenia. It is not immune thrombocytopenic purpura, because patients may present with thrombocytopenia, immune in nature, but without purpura, so that it is allowed to say immune thrombocytopenia. Duration-wise, new ITP is classified or stratified into 3 categories, depending on the duration. Newly diagnosed when the ITP is less than 3 months. Persistent when it is less than 100,000, but above 30,000. Newly diagnosed below 3 months. Persistent between 3 months and 1 year, Chronic ITP when the ITP is prolonged more than 1 year. Pathogenesis of ITP, usually it is autoimmune in nature. It is autoantibody in nature. Some antibody is attacking the platelets, but it is not the only mechanism against glycoprotein 2B3A, but also the cytotoxic T cell lymphocyte also they are blamed because 20 to 40% of our patients, they lack the antibody, the antiplatelet antibody. It is not only something related to peripheral destruction, but also something related to immunity against the megakaryocyte in the bone marrow. And we can see that the thrombopoietin as a hormone is not increased that much in parallel of the severity of the platelets that the patients have. Again, to the definition, we define ITP, primary ITP, when the platelets below 100,000 without other cause. And this is the classification in the International Working Group according to the duration. But still, ITP can be secondary to some other pathology or associated with something more than ITP. When the patient who has ITP presented also with anemia, you have to think of possibly, if it is not a bleeding, another autoimmunity, autoantibody against the RBCs, something called Evans syndrome. When the patient has more than one system involvement, including the kidney, blood pressure, or other lines, you may talk about something mimicking systemic lupus erythematosus, but this needs time to be diagnosed. When you are talking about some patient who has ITP, but hypogammaglobulinemia, you may end with a diagnosis of common variable immune deficiency. Some patients who are receiving some drugs, they have a thrombocytopenia. These are the secondary causes of ITP. Again, when to label a patient as responding to whatever you are giving regarding the treatment. When the platelets above 30,000, and now they are talking about 50,000, or more than 2-fold increase, 2 readings 7 days apart, this is some response. Complete response when the platelet is above 100,000, 2 readings more than 7 days apart. Shall I go and do a bone marrow examination in each patient with immune thrombocytopenia? The ASH, which is the American Society of Hematology 2011, recommends in those with typical features, it is recommended not to go for a bone marrow examination. Even in those who fail the IVIG, if they are fitting the criteria or there is no red flags to go for bone marrow examination, it is recommended not to do a bone marrow examination. Also, it is not mandatory, and there is suggestion not to do a bone marrow examination even before corticosteroids or even before splenectomy. This is a suggestion. This is a suggestion in the guideline, and you don't have to follow. You may follow. You may modify this according to your institute. A&E is not mandatory in each patient unless you suspect some autoimmunity or more than one system was involved. A big question, to treat a patient with ITP or not to treat. These 3 studies upon observation for patients who have only dry type bleeding, skin type of bleeding, no one of them had intracranial hemorrhage. On the other side, the intercontinental childhood ITP study group in 2,450 patients, only 3 developed intracranial hemorrhage in the pediatric age group, and they could define the following risk factors for the ITP. Head trauma, hematuria. Those who are having hematuria, keep an eye on them. They are more liable for intracranial hemorrhage than others. Those who are concomitantly on some drugs like non-steroidal, so that you have to avoid aspirin or non-steroidal anti-inflammatory drugs. Those who have AV malformation, some patients develop because of AV malformation, and most of the cases were in patients who have platelets below 10,000. Usually the intracranial hemorrhage presented in the first week after diagnosis. And the site was predominantly intracerebral, and it was more supratentorial rather in the posterior fossa. 70% of those who developed intracranial hemorrhage, they received some treatment before. And the survival rate is 75%. And unfortunately, 1/3 of those surviving, they have intracranial sequelae. And we have the 2019 ASH recommendations in the pediatric age group. This depends on assessment of a bleeding. Assess the bleeding rather than assess the number of platelets. Go to the bleeding, stratify the patient. Is the patient having minor bleed or major bleed? And you have to have a score of bleeding in your institute. WHO is a good score. CTCAE is also a good score for bleeding that you can follow in your institute. You say that the patient has remission if the patient has platelets above 100,000 after 12 months. These are the different modalities of treatment. Observation is still a modality of treatment that you may go for. Now, how to manage a patient who is newly diagnosed in the last 3 months as ITP? Shall I treat this patient as outpatient or inpatient? Again, assess the bleeding. If the patient does not have bleeding or has only mild bleeding means skin bleeding, no mucous membrane bleeding, you can treat the patient as outpatient, even if the platelets is below 20,000. This is a suggestion, not a recommendation, which means low evidence, but still it is in the guideline and it is followed in most of the institutes. But keep an eye, there is a big remark in the ASH 2019. If you are uncertain about the diagnosis, admit the patient. If the patient has some social concern regarding the father, he is very reluctant to discharge the patient. He is very afraid. He is very worried. Admit the patient. Those who live far away, admit the patient. Who you are expect that they will lack follow-up, also admit the patient. This is regarding the outpatient or inpatient. Shall I give a treatment or just observe a patient of ITP? Again, assess the bleeding. If the patient has only minor bleeding, which means skin bleeding, observation is enough. This is a suggestion by the ASH, American Society of Hematology. It is only observation, whatever the number. There is no comment here regarding the number. Assess the bleeding. If the patient has
can I interrupt Dr. Maher, please, on this point?
تفضل.
we have enough time, so we can discuss. Yes. Observation, regardless of even if the patient have very low platelets count, and suppose the patient have platelets count 2,000 or 3,000. Do you follow this recommendation by observation without treatment? Because in our according to guidelines in our institution, the adults, not for pediatrics. Yes, this is an indication for admission and IVIG and steroid therapy. Yes. So according to these guidelines, regardless to the number, even if the patient having a very low number of platelets counts.
Yes, I got the message, Dr. Ayman. Dr. Ayman, in the ASH, they have the adult type of a treatment and the pediatric type of treatment. As regarding the adult, you admit the patient if they are having below even 30,000 and even without that much bleeding or mucosal. In the pediatric age group, the observation is one modality in several studies. What we are doing in our practice, those below 10,000, still we are reluctant to observe these patients. We are reluctant. We are giving some treatment. Yes, above 10,000, we still observing them. This is the ASH. This is a suggestion. You don't have to follow, But when they followed these patients, even those who were having platelets below 10,000, observation was not associated with that much risk or even of intracranial hemorrhage. The pediatric age group behaved differently than the adult regarding the even spontaneous recovery. Now,
yes.
If the patient only has skin bleeding observation, we are talking about the skin. But usually, those patients who have platelets below 10,000, they have the other statement, which is a mucosal type of bleeding. Now you stratify. If the patient has non-life-threatening mucosal type of bleeding, now you have 3. This is the issue regarding most of the patients who have platelets below 10,000. They have some buccal mucosa bleeding or some epistaxis. Then you have to treat. Where to go? Shall I go for steroid, IVIG, or anti-D? Anti-D, I guess we don't have it, but in the ASH, they recommend to go for corticosteroids rather than the IVIG, corticosteroids rather than the anti-D. If you choose between IVIG and anti-D, you can go for either. Shall I give a long or short course of steroid? The ASH again, they are against long course of steroid. They are recommending less than 7 days of steroid. This is in the pediatric age group, and this is a strong recommendation. And they found if you give it longer, why? To have that side effect of the long-term corticosteroid, and the patient has a low risk of bleeding in pediatric age group. In patients who may have some spontaneous remission, even without, why to give a long steroid therapy? Now, it is recommended short course of steroid, 5 to 7 days, and that's all. Shall I give prednisolone or dexamethasone? They are recommending prednisolone over dexamethasone. Prednisolone in a dose of 2 to 4 milligram per kg per day, you can reach 120 milligram per day for only 5 to 7 days. And dexamethasone 0.6 milligram per kg per day, maximum 40 for 4 days. Those who fail or resistant, let's say resistant rather than refractory to first-line treatment, where to go on these patients? We have several options, either the TP or thrombopoietin receptor agonist or rituximab. Thrombopoietin receptor agonist we have in our institute the oral form. We don't have the injectable, which is the romoblastin. We have the L-Thrombobac, which is the Revolade, and now it is recommended. It was recommended in adults long before, after 2000, late 2015. Now you can give the oral form of TPO receptor agonist, which is the Revolade now, which is available. They recommend the oral over the rituximab. And if you compare between the TPO or splectomy, use the TPO, thromboid receptor agonist, rather than splectomy. If you don't have the TPO receptor agonist, and you are choosing something between rituximab or splenectomy, it is recommended or suggested to use rituximab as a bridge before splenectomy. Don't go for surgical. But still, this is an issue of sharing with the family. You have to share this opinion with the family. If the family has a long distance and they need some short-term type of a treatment with 75 to 80% success, they may choose a splenectomy, and you can go. This is suggestion. It is low evidence, but it is preferable to follow. Those who don't want surgical excision and they preferring some other modality, rituximab is a good choice. This is a good suggestion, but still you have to share your opinion with the family. So TPORA over rituximab, thrombopoietin receptor agonist over splenectomy, if it is rituximab or splenectomy, rituximab over splenectomy. And this is the summary of recommendations. Outpatient management for all patients, whatever the platelet. This is the new recommendation, assessment of bleeding rather than assessment of the number. in patients who have a skin type of bleeding, observation in patients who have a skin type of bleeding, corticosteroids who have non-life-threatening mucosal membrane bleeding, prednisolone short course, prednisolone rather than dexamethasone. But still the last slide, if you are treating a patient who has serious type of bleeding, where to go on this patient? You have to admit the patient. Give whatever you have in your hospital. You have to go and do what is called the immune shock for the immune system. Give platelets. Is it recommended? Yes, give platelets. Platelets will circulate only 3 hours, but we need these 3 hours to stop bleeding, especially in those who have intracranial hemorrhage. Give IV pulse therapy methylprednisolone in those who have serious hemorrhage. Give IVIG in a dose of 1 gram per kg. And you may be obliged to give even more recombinant factor 7A. And thank you. I am ready for any question. Amen.
Thank you very much, Dr. Maher, for this interesting talk. We are happy to receive a question. Anyone want to like to ask Dr. Maher any questions? صراحة دكتور ماهر في بوينت أنا حاب أضيفها صراحة على موضوع bone marrow study, as the guidelines recommend not to do bone marrow for the children. Also, I want to add that even in adulthood, even in patient in adult hematology, also the recommendation is also not to go for bone marrow study for the patient who presented with typical findings of ITB. This is the guidelines since about 1 decade. For that, they are recommended to do bone marrow, especially for those who are older age or older than 50 years. But since the last decade, the recommendation even in the adult, there is no need to do bone marrow study for the patient who presented with the typical picture of ITB. Just أنا حبيت أضيف على هذا الحكي يعني. There is I note some differences between management between adult and children, but yes, but this is a very important point I حبيت يعني أحكيها. I think we have still time, so floor is open for questions. Any question from the audience? Okay, thank you, Dr. Maher again. It's time to go for yes. شكرا كثير الله يعطيك الف عافية. Thank you very much. Now we move to our next speaker, Dr. Jumana Nahal. Dr. Jumana, she is a specialist in clinical pathology hematology, and currently she working as hematological or hemopathologist at Al-Bashir Hospital in the Ministry of Health. Dr. Jumana will talk about pregnancy and neonatal hematology and neonatal anemia and pregnancy and neonatal period. Dr. Jumana, please, you can start your talk. Dr. Jumana. Dr. Jumana, you can start if you are there. It seems Dr. Jumana not available at this moment. By the end of this talk, Dr. Matt talk, I want to thank all our colleagues for today who presented this excellent lectures. Also شكرا كثير لكل المنظمين لهذا المؤتمر. And this is the end of the hematological section of this conference for today. And thank you very much. Thank you all. يعطيكم ألف عافية.
Thank you.
يعطيك ألف عافية دكتور، وشكرا شكرا كثير لكم ولحضوركم وللسبيكر اللي أعطوا. ما شاء الله محاضرات قيمة.
الله يعطيك العافية بتول، شكرا لك.
الله يسعدك.
مجهود مبارك إن شاء الله ويعطيك ألف عافية. شكرا.
الله يعافيك.